Okay, so imagine this, right? Your heart, it's a bustling city,
Okay.
and the mitral valve, that's like this vital bridge controlling traffic between two really key districts. Now, picture that bridge narrowing, creating a bottleneck, right? Slows everything down.
Oh, yeah.
That's mitral stenosis for you.
Yeah.
But what if, and here's the kicker, there was a way to widen that bridge? No major construction needed, though, and that's where the closing procedure comes in. Balloon mitral valvotomy, BMV for short. It's minimally invasive and can be seriously life-changing. So today we're going deep, really deep into this fascinating procedure. And we've got to give a big shout out to the London HeartbeatsZ Academy, UK.
Oh, yeah.
They provided us with some incredible educational material, seriously top-notch stuff. So if you're ready to explore, like really get into the heart's inner workings and unlock all the secrets of BMV, well, you've come to the right place. And oh, don't forget to subscribe to our channels, Facebook, Instagram, Spotify, and YouTube. You get all the latest deep dives, fascinating discussions, all that good stuff.
It's amazing, isn't it? How this seemingly simple procedure can make such a big difference.
Absolutely.
So to really get it, let's start with a picture of the mitral valve, all right? It's situated between the left atrium, which gets that oxygen-rich blood from the lungs, and the left ventricle, the heart's powerhouse pumping chamber.
So it's like a one-way gate, making sure traffic flows smoothly in our heart city.
Exactly. But here's the thing with mitral stenosis, that gate, it gets stiff, narrowed, it blocks that smooth blood flow.
Ah.
And that can lead to a backlog in the left atrium, causing all sorts of problems. Fatigue, shortness of breath, even those funky heart rhythms.
So BMV swoops in like a specialist to widen that gate, restore that smooth flow.
You got it. And the best part, no open heart surgery needed. But before we jump into the how, let's talk about the who. Not every patient with mitral stenosis is a good candidate for BMV.
So there's a selection process, kind of like choosing the right team for a delicate job.
Absolutely. The decision to go with BMV depends on a few things, like how severe the stenosis is, the patient's symptoms, and their overall health. And we've got this classification system, right?
Right.
To categorize patients based on how much we recommend the procedure. Class I indications are the clearest, most straightforward. These are patients, well, they're really feeling the effects of that narrowed valve, experiencing symptoms. They'd benefit a lot from the procedure.
So you're feeling the effects of that bottleneck. Your valve is significantly narrowed. BMV's looking pretty good.
Yeah.
But what about those who aren't showing any symptoms?
Yeah, that's where it gets a bit more, tricky. Even without symptoms, a really severe stenosis can stress the heart over time. These patients, class 3, we might consider BMV for them, especially if their valve structure is good for the procedure.
So it's not just about feeling bad right now. It's about preventing problems down the road.
Exactly. Then we have class I a bit, patients who have developed atrial fibrillation, that irregular heartbeat, because of their mitral stenosis. In these cases, BMV can tackle both problems, the valve and the rhythm.
Two birds, one stone. It sounds like doctors carefully weigh the potential benefits and risks for each patient. Now, are there ever times when BMV is completely off the table?
Oh, absolutely. Some conditions make BMV just too risky. For example, if there's a blood clot in the left atrium, doing the procedure could dislodge it, and that could lead to a stroke. That's a definite no-go.
Makes perfect sense. Safety first. Anything else on that no list?
Well, excessive mitral regurgitation, that's when the valve's leaking a lot, is another no-no. BMV could actually make the leakage worse. And lastly, if the valve is super calcified, think of it like hardened bridge supports, it might not respond well to balloon dilation.
So it's all about choosing the right tool for the job. BMV is precise, not a sledgehammer. But let's say a patient meets all the criteria, they're a good candidate. What does a successful BMV look like? How do you measure success?
Success is a two-parter. First, we want to see a good increase in the valve area, ideally over 1.5 square centimeters. That means we've widened that passage for blood flow, right? Second, we got to make sure we haven't created or worsened any leakage. We measure that with a grading system for mitral regurgitation, and we aim for a grade 2 or lower, ideally.
So it's not just opening the valve, it's about doing it safely, without causing new problems. Now, I'm picturing a set of specialized tools for this procedure, for this delicate work. What does the BMV toolkit look like?
It's actually pretty fascinating, the instruments we use. They're designed to navigate the heart's pathways and manipulate the mitral valve, but gently, of course. One key player is the Mullins sheath. Think of it as a flexible tunnel, usually 6 or 8 French in diameter, about the width of a drinking straw. It guides the other instruments to the heart.
So like creating a protected pathway to the operating site. What else is in this cardiac toolkit?
Well, there's the Brockenbrough needle, a special needle used to puncture the wall between the heart's upper chambers. It's like creating a temporary door between the right and left atria. Gives us access to the mitral valve from a strategic angle.
I can only imagine how important precision is when using an instrument like that.
Absolutely. The Brockenbrough needles come in different sizes for different patients, and the tip is curved for smooth entry. Then we've got the balloon catheter, the star of the show. It's a thin, flexible tube with a tiny balloon at the tip.
This is the tool that actually pushes open the narrowed valve. How do they get it in the right spot?
That's where the stylet comes in. It's a stiff wire that goes through the catheter, gives it the rigidity we need for accurate placement. And for smooth passage, there's the dilator. It's a tapered tube that gently enlarges the opening made by the needle.
So it's like a whole team of specialized tools working together for a common goal.
Exactly. And to round out the toolkit, we have a stretching tube to prep the balloon, a guide wire for navigation, a syringe for injecting fluids, and a caliper for measuring. Each tool plays a crucial role in the procedure's success.
Like a miniature orchestra, every instrument contributing to the harmony. Now, before we dive into the actual steps of the procedure, let's take a moment to appreciate the 3D anatomy of the heart. It's got to be important to understand that, right?
Oh, you're absolutely right. It's not just about having the right tools, it's about knowing the landscape. Imagine navigating a complex maze and need a map,
Yeah.
In BMV, that map is understanding the interatrial septum, the wall we puncture to reach the mitral valve.
So it's like having the blueprints of the heart's architecture.
Exactly. And we use this cool analogy, the watch, to guide needle positioning. Imagine looking at the heart from the front. The interatrial septum is like a clock face. The fossa ovalis, a naturally thin spot in the septum, is our target, usually between 4 and 6 o'clock.
The bullseye on our cardiac clock.
Precisely. But the exact location. That can change depending on the patient's heart size and structure. For instance, a larger heart might shift the fossa ovalis lower, closer to 7 or 8 o'clock.
So it's not one size fits all, more like tailored to each person.
Exactly. A smaller heart might have the fossa ovalis more towards the front, around 3 to 4 o'clock. Knowing these variations, absolutely crucial for safe and accurate puncture.
It's like adjusting your compass based on the terrain.
A perfect analogy. And to make things even more precise, we have different Brockenbrough needles with varying curves. The BRK1 needle with a gentler curve might be perfect for a flatter septum. But the BRK needle with its more pronounced curve could be better for a curved septum, which is common in mitral stenosis.
It's fascinating how even those tiny anatomical differences can change the tools and techniques used.
And we can even adjust the needle's curve ourselves by gently bending it to match the patient's anatomy. It's this level of precision that makes BMV such a remarkable procedure.
Like tailoring a suit, every detail matters. Now, how do doctors actually see the puncture site during the procedure?
That's where fluoroscopy comes in. It's like a live X-ray video. Lets us see the needle, the catheter, and all the heart structures in real time.
Like a GPS guiding us through the heart's pathways.
Exactly. We use different techniques to pinpoint that ideal puncture site on the septum, all using fluoroscopy. One way is using bony landmarks, specific points on the vertebrae and ribs as reference points.
So they're using the skeletal structure as a guide.
Precisely. Another way is visualizing the relationship between the septum and the mitral annulus. That's the ring of tissue around the mitral valve.
And where does that watch analogy come in here?
Well, that clock face helps us orient ourselves inside the heart, making sure the needle's angled right towards the target on the septum. We use different views during fluoroscopy too, to confirm the needle's position and avoid problems. The RAO view, that's right, anterior oblique, lets us check that the needle's clear of the aorta and the coronary sinus. Those are critical structures we don't want to puncture.
Like having multiple camera angles to ensure they're in the right spot. What other views do they use?
The lateral view is important. It shows the needle's position in relation to the spine, confirming we're in a safe zone. And for even more precise targeting, there are specialized techniques like the Hung's method and the INMU method. They use specific landmarks and contrast dye to pinpoint the best puncture site.
It sounds like they're combining anatomical landmarks, real-time imaging, and sophisticated techniques to navigate the heart.
Absolutely. And to make sure we've actually touched the septum with the needle, we use techniques like the septal flush and the septal stain. Contrast dye injected through the needle creates signs we can see on the fluoroscopy images.
A double check, making sure they're in the right spot before moving on.
Exactly. So we've laid the groundwork. We understand the anatomy, the tools, and the imaging. Next, we'll walk through the actual BMV procedure step by step, using those fluoroscopy images as our guide. All right, so welcome back to our exploration of balloon mitral valvotomy. We've just laid the groundwork, right? Understanding the anatomy, the tools, and all that imaging guidance.
Yeah, it's like we've prepped our surgical team, mapped our route through the heart, the intricate landscape.
Precisely. Now let's step into the operating room, so to speak, and actually walk through the BMV procedure. We'll use those fluoroscopy images as our guide.
I'm ready to see this delicate dance in action.
Yeah.
Lead the way.
Okay, imagine looking at the heart in the RAO view. That right anterior oblique perspective gives us a clear view of the septum. Our first challenge is getting the catheter through the right atrium, aiming for that carefully chosen puncture site.
It's like threading a needle in a moving haystack.
You got it. It's a great analogy. And it gets even trickier if the left atrium is small.
Why is a small left atrium such a challenge?
Well, the ideal puncture site might be too close to the mitral valve itself.
Oh, so the balloon could hit the valve before it's even in position.
Exactly. Plus, there's a higher chance of the catheter tip going into the pulmonary veins, those delicate vessels bringing oxygen-rich blood from the lungs. We definitely want to avoid that.
So small left atrium, extra caution needed. What's the strategy there?
Sometimes we reshape the guide wire, create a tighter loop for better control of the catheter, or we might adjust the puncture site a bit, move it more laterally for a safer approach.
Like adjusting course to navigate a narrow passage.
Precisely. Now, if the left atrium is enlarged, the challenge is accurately pinpointing the midline.
That's the vertical line they use in the Hung's method to find the ideal puncture site, right?
You got it. But with an enlarged left atrium, its border on the fluoroscopy image might look misleadingly medial to the right atrium border.
So it creates kind of optical illusion, throwing off your aim.
Right, we have to carefully adjust our landmarks to make sure we're targeting the true midline. Another key decision before puncturing the septum is whether to use a patent foramen ovale, PFO, if there is one.
Remind me, what's a PFO again?
It's a small hole in the septum, a leftover from fetal circulation. Most adults with a PFO don't have any issues, but for BMV, it could be a shortcut.
Like a pre-existing doorway in our cardiac maze.
Exactly. Puncturing through a PFO might give us a more direct route to the left atrium and maybe even reduce the risk of certain complications, like accidentally puncturing the aorta.
Sounds good. Any downsides to using a PFO?
Well, the PFO might not always be in the perfect spot for crossing the valve, and there's a slight risk of making the hole bigger, which might need closure later.
So it's a trade-off, weighing the pros and cons.
Exactly. Okay, now let's go through the actual steps of the procedure, using those fluoroscopy images as our snapshots, capturing the key moments. In the first image, you see the catheter. It's being threaded through the right atrium towards the septum, guided by that real-time fluoroscopy feed.
It's amazing how they can navigate such a complex dynamic pathway using those live images.
It really is. In the next image, the Brockenburr needle is gently inserted through the septum, creating that passage into the left atrium.
And how do they know they've actually entered the left atrium? That seems like a critical moment.
You're absolutely right. Confirming entry is crucial. We use 3 things to confirm. First, we aspirate. That means draw back blood through the needle. If it's bright red, we know it's oxygenated blood from the left atrium.
So bright red, we're in the right spot. What else?
We also measure the pressure in the left atrium. It should be much higher than the pressure in the right atrium, which confirms we're in the correct chamber.
Pressure readings, another signpost on our journey. What's the third confirmation?
We do a left atrial angiogram. We inject a special contrast dye into the left atrium so we can clearly see its size and shape on the fluoroscopy screen.
So it's like highlighting the destination on the map,
Yeah.
making sure we're in the right place.
Exactly. Once we're sure we're in, we carefully move the needle towards the mitral valve. The next step is super important. Threading the catheter over the needle and into the left ventricle.
This is where things could get a bit tricky, I imagine.
It can be. If the catheter doesn't go in smoothly, it could get caught in the interatrial septum.
So what happens then? Do they have to start over?
Not always. Sometimes we can use a coil wire to gently nudge the catheter further into the left atrium, or we might need to dilate the opening in the septum a bit more, using the dilator to make more space.
Like widening a doorway for a bigger piece of furniture.
Perfect analogy. Another snag can happen if the balloon itself gets caught in the septum.
How does it happen? It seems like it should pass through easily,
It's more likely if the septum is really thick. The balloon might get hung up as we advance the catheter.
like trying to squeeze a round peg through a too small hole.
Exactly. In those cases, we might gently twist the stylet, that stiff wire inside the catheter, clockwise. That helps get the balloon perpendicular to the septum, making it easier to move forward.
So it's about finding the right angle and applying gentle pressure.
Precisely. Once the balloon is in position across the mitral valve, the real action begins. Balloon inflation.
This is what we've been building up to, the grand opening, right?
It is. We carefully inflate the balloon with saline and contrast dye. This gentle expansion pushes against those narrowed valve leaflets, forcing them apart.
Like stretching a stiff rubber band, restoring its flexibility.
Great way to picture it. The fluoroscopy screen shows us the balloon expanding and lets us carefully watch its position in the valve.
I imagine there are different ways to maneuver the catheter and balloon to get the best position for dilation.
Absolutely. We've got a few approaches, each one tailored to the patient's specific anatomy.
I'd love to hear about these different techniques. It's like a cardiologist's ballet.
Let's start with the vertical method. Picture a pendulum finding its balance. We often use this when the catheter is positioned deep in the left atrium. The key is to withdraw the stylet a little while holding the catheter steady.
So you're making the tip of the catheter more flexible. Why is that important?
It lets the balloon line up more naturally with the mitral valve, just like a pendulum finding its center. Fluoroscopy images taken during diastole, when the heart's relaxed, and systole, when it's contracting, show how the balloon gently finds that valve opening.
Wow, they use the heart's own rhythm to guide the procedure.
It's pretty amazing. Now let's move on to the direct approach. This one's, well, more direct, as the name suggests. We just withdraw the stylet and move the catheter straight toward the mitral valve.
Sounds efficient. What are the advantages of that approach?
It's quick and effective when the anatomy allows it. It's a smooth transition from septal puncture to valve dilation.
The express route. What other techniques are in the cardiologist's toolkit?
Another option is the horizontal or sliding method. This is really useful when the heart's lying more horizontally in the chest.
So again, adapting the approach to the individual's anatomy.
You got it. With this method, we carefully adjust the stylet inside the catheter, using it to steer the balloon tip towards the mitral valve.
The stylet's like a tiny rudder guiding the balloon.
Perfect analogy. It's a delicate dance of adjusting the stylet while moving the catheter forward. Fluoroscopy images show us how we get that precise control of the balloon's position.
It's incredible how they make those tiny adjustments inside a beating heart. Any other techniques we should know about?
The last one we'll discuss is the posterior loop method. This one's a bit more advanced. We create a little loop in the catheter behind the heart.
A loop. That's interesting. Why is that necessary?
Creating that loop helps align the catheter with the long axis of the left ventricle, making it easier to cross the mitral valve.
It's like creating a smoother path for the catheter to follow.
Exactly. We manipulate the stylet to make the loop and then advance the catheter using fluoroscopy to guide us.
So it sounds like each technique has its own strengths, its own weaknesses, and they're chosen based on the individual patient.
That's exactly right. The key is to know all the techniques and pick the one that gives the best chance of success with the least risk. Now, once that balloon is perfectly positioned across the mitral valve, another big decision comes up: choosing the right balloon size for inflation.
That sounds like a make or break moment. How do they figure out the right size?
It's a mix of art and science, really. The patient's height, how severe the stenosis is, the overall condition of the valve, all of that matters. We use a table to guide us in selecting the right catheter and balloon size based on the patient's height. We calculate a reference size using a simple formula based on their height in centimeters.
So taller patients, bigger balloons generally.
Generally, yes, but height's only one part of it. The condition of the valve is just as important. If the valve's still pretty flexible, we usually go with a balloon size that matches that calculated reference size.
So flexible valve, matching balloon. What about a heavily calcified valve, like we talked about before?
If the valve is calcified or very tight, we might use a slightly smaller balloon to avoid overstretching it and causing damage.
Makes sense. Too much force could backfire.
Exactly. And then there's this idea of a low-pressure zone and a high-pressure zone to think about when inflating the balloon.
Okay, I'm curious. Tell me more about these pressure zones.
The intra and new pressure chart, that's a helpful visual guide. It shows how the pressure inside the balloon changes as the balloon gets bigger. The low-pressure zone is the safe zone. Pressure stays relatively low, less risk of complications.
So that's the sweet spot. Effective dilation without pushing the limits.
Exactly. The high pressure zone, that's where it gets riskier. If we inflate the balloon too much, pushing it into that zone, we could cause problems like mitral regurgitation. That's when the valve starts leaking.
So it's all about finding that Goldilocks size. Not too big, not too small, just right to open the valves safely and effectively.
You got it. Choosing the right size and inflating it to the correct pressure, those are key for a successful outcome. Speaking of outcomes, we should also talk about the things that could go wrong during this procedure, the potential complications.
And we're back for the final part of our deep dive into balloon mitral valvotomy. We've gone through the steps, from patient selection to the balloon positioning and inflation. It's been quite a journey.
It has a real exploration of the heart. But like we said before, no procedure is completely risk-free, especially when it comes to the heart. So we need to talk about potential complications.
Absolutely. What are some things that could go wrong during BMV?
Well, one thing is bleeding, or a hematoma forming at the puncture site. It's kind of like a bruise where the needle went in. Usually it's not a big deal. We just apply pressure and keep an eye on it.
Like a little detour on our cardiac journey, nothing too serious.
Exactly. Another possibility, though it's rare, is cardiac perforation. That's when the needle accidentally punctures the heart wall itself.
That sounds serious. How do they deal with that?
It's definitely something that needs immediate attention. Cardiac perforation can sometimes lead to cardiac tamponade, which is when blood leaks into the space around the heart.
And that's a problem
Because that leaked blood can actually put pressure on the heart, making it harder for it to pump properly.
So it's like squeezing the heart, restricting its ability to do its job.
Exactly. Luckily, with quick action and treatment, cardiac tamponade can usually be managed effectively. There are other, less common complications too, like air embolism, where air bubbles get into the bloodstream, and arrhythmias, those irregular heart rhythms.
So there are a few potential hiccups, but it sounds like doctors are prepared to handle them.
You bet. Careful patient selection, precise technique, and that real-time imaging guidance, it all helps to minimize those risks.
Stacking the odds in the patient's favor. Now, you mentioned stitch phenomenon earlier. What exactly is that?
Ah, yes. The stitch phenomenon, that's something we see specifically with transeptal puncture when we create that temporary opening between the atria.
So it's related to the way they access the mitral valve.
Exactly. Imagine a tiny tear in the septum, like a loose stitch in fabric. That tear can let a little bit of blood seep into the pericardial space, the sac around the heart.
So it's more of a slow leak than a sudden gush.
Great analogy. And the thing is, this leak might not be obvious right away. It can take a few minutes for enough fluid to build up around the heart to cause a problem.
Like a delayed reaction, something to watch out for.
Right. After we puncture the septum, we always wait a few minutes, watch the patient's blood flow and pressure, and do an echocardiogram to check for any fluid buildup around the heart.
So it's a wait-and-see approach, ready to act if they need to. What if they do see fluid building up?
If it's just a little and the balloon catheter's already in, we might go ahead with the BMV. Interestingly, the procedure itself, by lowering the pressure in the left atrium, can actually help reduce that leak.
So the treatment becomes part of the solution. That's fascinating. What if the fluid buildup is more significant?
If we've already dilated the septum, we leave the dilator in, and the patient is monitored closely in the cardiac ICU. We might even reverse the heparin, the blood thinner we use, to help with clotting and stop the leak.
So they adjust their strategy based on what's happening, always putting the patient's safety first. Now, we've talked a lot about the technical stuff, but what's the experience like for the patients?
Well, it's definitely a bit nerve-wracking, no doubt about that. But knowing that this minimally invasive procedure can really improve their life, that can be a big comfort.
So it's like facing a challenge, but for a good reason, a brighter future with fewer limitations.
You've got it. And recovery is usually pretty quick. Most patients go home the next day and can get back to their normal activities within a few weeks.
That's good news. A quick recovery is a definite plus. Before we wrap things up, let's go back to those long-term outcomes. We've covered the how of BMV, but what about the what next?
Yeah, that's a really important question. AMV offers a lot of improvement for patients with mitral stenosis, but it's not a cure-all.
So it's like gaining time, improving quality of life, but not necessarily a permanent fix.
That's right. The valve can narrow again over time, and that might mean needing another procedure or even valve replacement surgery down the road.
That makes regular checkups even more important, right?
Absolutely. Those checkups are vital to keep track of how the valve's doing and catch any problems early. It's also important to remember that BMV is just one of the tools we have for treating mitral stenosis.
So it's not a one-size-fits-all solution.
Nope. We also have medications to manage symptoms and surgical valve replacement for those more severe or complex cases. The best treatment really depends on each individual patient.
It's like a toolbox, different tools for different situations. Well, we've learned a lot about BMV today, all thanks to those fantastic materials from London HeartbeatsZ Academy in the UK.
They do great work, really dedicated to education.
And to our listeners, thanks for joining us on this journey through the heart. We've explored the anatomy, the tools, the techniques, and the potential complications of this incredible procedure. If you enjoyed this deep dive into balloon mitral valvotomy, don't forget to subscribe to our channels, Facebook, Instagram, Spotify, and YouTube for more deep dives like this one. We've got lots more fascinating topics coming up.
Until next time, stay curious and take care of your heart.